Let's talk about test results. What sort of tests should be done following a myelofibrosis diagnosis?
Well, I think this is something that's an active area of evolution. I think the good news is I can give you a few standard items. I think most, if not all, of our patients will require a bone marrow biopsy to be done at baseline and possibly even later on to assess the status of the therapy. Now, in some cases, that may not be available or accessible due to patient preference or comorbidities, but a bone marrow biopsy is the way to look inside, see how the bone marrow tissues are doing. Outside of that, for the blood tests, the two most critical sets are what we call a CBC and a CMP. So CBC, complete blood count. This is where you get your hemoglobin, platelets, white blood cell count, very important to know at baseline and dynamically. And then the complete metabolic profile is very important, Catherine, because we need to know how the potassium, kidney function, liver function are doing. And then finally, I would also say you'll see your provider add in other blood tests over time, depending on the particular case. Thyroid testing, if it's needed, in the case of fatigue, just to name one example. So I think these are the main categories. I think what's also interesting over time is that this is an issue with us as well in the MPN clinic, is that you end up seeing your MPN provider and team so much that it's easy to forget and lose sight of the primary care items too. So it's a good time to remind folks to stay in touch with that, with their MPN team, the provider, and their caregiver, whether it's colonoscopies, mammogram, prostate. And I remember over the COVID pandemic time, especially, a lot of that was either sacrificed, forgotten, or on purpose put aside. So let's remind people in 2024 to remember to have that partnership as well.
Mm-hmm. How does molecular testing affect treatment options and prognosis?
Right. Yeah, I haven't mentioned that yet because that's something that we're trying to layer into. And I do find that to be standard of care now in the treatment of myelofibrosis. What you're asking about is very important. So outside of the normal labs and bone marrow morphology, seeing what it looks like under the microscope, we're starting to add 3 or 4 items. One is called cytogenetics. That's chromosomes. You're born with 46, so 23 from mother, 23 from father, for example, 46 total. And even though most people are not born with an MPN per se, those chromosomes can change and become abnormal over time. So we want to know that, and that can help us tell low versus high versus intermediate risk. 2 is the molecular test you ask about. Most people have heard of JAK2. That's the most common out of myelofibrosis, maybe 50 to 60% of cases, JAK2 V617F. But did you know there's also CALR, which is the second most common molecular mutation, and then MPL or MPL. Those 3 are the big 3 driver mutations. They make up roughly about 90% of our cases, 10% being so-called triple negative, so you're negative for all 3. When you do deeper sequencing, which is available now clinically, and we check that here, you will find almost always some other mutation, ASXL1, EZH2, SRSF2, et cetera. It becomes an alphabet soup very quickly, but I think basically you should know that there's JAK2, CALR, MPL, the big 3 driver mutations, additional molecular mutations. And so therefore, we and others believe you should check these as standard. And then finally, there's also flow cytometry. Just want to give a shout out to that. Most people haven't heard of that. When you send your bone marrow for testing, in addition to the pathologist looking under the microscope with the human eyes, there's also a test that does side scatter of light called flow cytometry, which helps to look at a deeper level, maybe the 1,000th, maybe even down to the 1,000,000th level. What are these cancer cells doing?
Mm-hmm. What sorts of questions should patients be asking about test results?
I think the number 1 and number 2 questions that I advocate for patients or on programs like this, I think the one question that may help a lot is this question of when you hear all the data and ask the question, hey, is there any other questions I should be asking and missing? It's an interesting question, right? It's like almost a meta, right, kind of a situation. But when you ask that, every time I've been asked in the clinic, it makes me pause and say, now that you mention it, X, Y, Z. So I think it's a good one to ask either your physician or whoever, healthcare provider in the room, again, nurse, PA. It's an interesting one, right? It kind of makes someone maybe even put themselves in your shoes. So I like it as a device to make people pause in a busy clinic. Yeah, the second question that I think is a good one is to say, while things are going well right now, I wanted to ask you, Doc, what are some things that could happen in the next 6 months, 1 year, or 2 years, adverse events or abnormal things? And is there something I can do to plan for it? Again, maybe somewhat of a theoretical question. Doctor may say, okay, right now things are going well. but it kind of makes people think about contingency plans, alternative things. Well, now that you mention it, there is this one side effect of this drug. I don't know. I think those are two kind of go-to questions that I want people to be equipped with.